Okay, everyone, I just want to say thank you again for coming and introduce to you our presenter, Katy. She is from the Illinois Maternal and Child Health Coalition, and she is the Policy and Communications Coordinator. Yeah. Okay, great. And so she is going to talk about the Affordable Care Act, kind of a follow-up to our discussion in November. If you guys, anybody was at that event in November? Oh, cool. Good. Glad to see a show of hands. So she's going to get a little bit more down and dirty about the Affordable Care Act and hopefully allow a lot of time for questions and answers. She's really great, really knowledgeable, so just ask away, okay? So without further ado, Katy, take it away.
Thank you very much. Thank you. So I have a PowerPoint presentation I'm going to pass around for everyone, so you can follow along and take some of this information home with you. Oh, that's really kind. Thank you very much. No problem. Thank you. So as those are going around, I will give a little introduction. I am Katy Waligora with the Illinois Maternal and Child Health Coalition. The Illinois Maternal and Child Health Coalition is a policy-focused organization working to improve the health of women, children, and families across the state of Illinois. So you'll see the second slide in the presentation that I just gave you has a whole list of the projects that we lead. Health reform is a small part of what we do, but a very, very important part, especially as we're marching towards January 1st of 2014, which is just a few months away. So what we'll talk about today, I planned kind of a truncated version of my usual presentation. So I'll let you know, I'm assuming many people in the room are practicing social workers. Are there any students? One of you. Okay, great. So I will say that I have a much longer presentation than I usually do, and that I'm available to facilitate for free for your agencies, groups, community groups, anyone who wants to listen. I'll come to your knitting club, it doesn't really matter. Because that's the beauty of the Affordable Care Act, right? Is everybody needs to hear this information for one reason or another. So what I'll talk about today is a sort of condensed version, and I have a lot of time for question and answer, because I wanted to get to the things that were most important to you guys. So I'll do a quick overview of the law. I will not tell you about everything that's in the law. We're at, I think, 2,000 pages of law and about 15,000 pages of rules. We don't have time for that. So I'll talk a little bit about some of the major provisions. Then we'll talk through the three main pathways to affordable coverage beginning in 2014. Because I think when we think about putting boots on the ground and enrolling people, that's what's really going to matter. And then I'll talk about some of the outreach and enrollment work that we're doing, because we really see the next few months the most critical need is to actually educate folks on this law and connect them to coverage. And I'll talk about the role that you all can play in that. So without further ado, we'll jump into the key components of the Affordable Care Act. So this is the third slide, last one on the first page. I'm not going to talk about all of these, but I wanted to give you guys a sense of some of the things that are in place. The Affordable Care Act was signed just over 3 years ago, so March 23rd, 2010, and there have been a lot of highlights and victories and successes along the way. There's a common misconception that the law was signed in 2010 and it's going to start doing things in 2014, and we try to emphasize whenever possible that that's not the case. There are many things that are happening today, and you're probably benefiting in a lot of ways, and you just don't even realize it's because of the Affordable Care Act. So one of the things I do want to mention that's available now is county care. Just by a show of hands, who's heard of county care? Awesome. So about half the room has heard of this program. County care is a new Medicaid program made available as a result of the Affordable Care Act. And I put some flyers up on this table if you want to grab some on your way out. County care, to put it briefly, is the early expansion of Medicaid in Illinois. So we know in 2014 Medicaid will be expanded nationwide. And the way that's going to happen is the law will actually turn Medicaid into what people who never understood Medicaid always thought it was, which is health insurance for people under a certain income. A lot of people don't know about the categorical eligibility, though I'm assuming all of you do, right? In order to qualify for Medicaid, you have to have income under a certain threshold, which is different for different populations. But you also have to be a child, a custodial parent, a pregnant woman, elderly, or disabled. So in 2014, we're going to expand Medicaid by getting rid of those categories. That's already happening today in Cook County, actually well before today. So folks who are living in Cook County, who are U.S. citizens or legal permanent residents of 5 years or more, and who have incomes under $15,000 for an individual and about $32,000 for a couple, qualify for county care. All of this is on the flyer, so don't feel like you have to frantically scramble. There are about 250,000 people who fall into that group, that eligibility group that I just mentioned. These are, for all intents and purposes, childless adults. Those are the only people who are under that income threshold who don't already qualify for Medicaid. So it's a really exciting opportunity, especially if you work with men, but a lot of those people are men. It's really easy to sign up. You just call the phone number or stop into a Cook County Health and Hospital System facility. It is completely free. There are no co-payments or any other fees associated with county care, which is a slight change from family care. Otherwise, the benefits are a lot like family care. Anything else I should mention on here? That's really, when we look at what's available now, I would say the most important on here. When we look towards 2014, you see there's a huge list here, but the way I want to talk about 2014 is to turn to the next page and the next set of slides and think about the 3 pathways to affordable coverage that will be available beginning in 2014. So beginning on January 1st, 2014, here's a handout for you. Thank you. No problem. So beginning on January 1st, 2014, there are going to be 3 primary ways that people will access affordable coverage that are not currently available, right? So people who are enrolled in employer-sponsored coverage will continue to enroll in employer-sponsored coverage. Folks can certainly go from insurance company to insurance company the way that people in the individual market do now. Those systems will always exist. But these are 3 new opportunities to become insured. And I gave them this little Venn diagram because there is considerable overlap between all 3 programs. So we'll start by talking about tax credits and subsidies. So beginning in 2014, many people are actually going to have help paying for their health insurance for the first time. So this is called the Affordable Care Act. And by calling it that, we required that we have to define affordable, right? Someone had to determine what in fact is affordable health insurance. So the federal government brought together a bunch of people who know a lot more than I do, and they did all of the math and they decided that affordable coverage is health insurance coverage that does not cost more than 9.5% of a person's annual income. So I'll say it again. Affordable coverage should not cost more than 9.5% of someone's annual income. So once they, yes?
Okay, so it can be lower than 9.5%.
Yes, so the question is, can it be lower? And the answer is absolutely. You can definitely pay less than 9.5%.
And how, I mean, I work with a lot of working poor people, $20,000 a year. The concern is, I mean, a lot of them don't have any insurance. The concern is 9.5% of $20,000 is a lot more than they can pay.
So, just so everybody knows, I'm going to be repeating your questions for the recording, but what was just explained is that you work with working poor, many making only $20,000 a year, 9.5% might still be too much. And that's certainly a concern that is echoed by a lot of advocacy groups. So it's possible that folks who fall into the group you mentioned might actually get support that makes it where health insurance is even less than 9.5% of their income. That's just the threshold that's been established. So we'll talk about tax credits and subsidies in Medicaid, and then if that doesn't help you, we can definitely come back to this. So tax credits and subsidies, because we've defined affordability as 9.5% of annual income, we have to make programs available that help people get underneath that threshold, right? It's no good to define affordability and then leave people to pay more than that. So we've established this program by which folks will apply for tax credits to help pay the cost of their premiums, and subsidies to help pay the cost of out-of-pocket costs and deductibles, co-payments, things like that. So tax credits will look a lot like discounts on your insurance premium. So the folks who qualify for tax credits would be people between 100 and 400% of the federal poverty level. So 400% of the federal poverty level is a lot higher than I would guess even most social workers know, right? Because a lot of our programs don't go up that high. So 400% is $93,700 annually for a family of 4. So it's a much wider group than most social safety net programs. It's really going to hit a lot of middle income families. These discounts will, or these tax credits will, like I said, appear like discounts. The way it'll work is at the beginning of the year, you will estimate your income, right? So that's an important education point when we're working with community members, clients, families. We need to make sure that people are making the best estimate of their income possible. You will report your income on the marketplaces, which we'll talk about, and then that, based on your income, you'll receive a certain amount from the federal government to help pay for your health insurance premiums. But rather than having to pay your premiums every month, knowing that you're getting this tax credit at the end of the year, it will actually be applied as a discount, and that tax credit will be sent to your health insurance provider. So if you receive the tax credit, really what that means is you're going to receive X% off of your premium every month. Additionally, we've got these subsidies that will help pay out-of-pocket costs. So we don't know exactly how these are going to be issued to folks because we haven't seen the final rules yet. But it'll be some sort of probably cash payment or rebate to individuals between 100 and 300% of the federal poverty level. That's about $70,275 for a family of 4 annually. So these subsidies will be intended to help people pay the cost of co-payments, deductibles, and other out-of-pocket expenses, recognizing that premiums are not the only cost barrier when we talk about accessing health care. So that covers a pretty big portion of people, right? 100 to 400% of the federal poverty level. But then we've got Medicaid, which covers people between 0% of the federal poverty level up to 138. So this is where we have a little bit of overlap, right? So in 2014, as I already mentioned, we will expand Medicaid across the country to cover folks up to 138% of the federal poverty level. Again, we'll do that by eliminating those categorical eligibility requirements. So the group mostly impacted will be childless adults, whether they're single or married. Once you have a child, if your income is at 138, you would probably qualify for traditional Medicaid programs. Those traditional Medicaid programs will still exist.
Which is like the same from years ago called GA, General Assistance.
Right.
Money and a Medicaid got all those years.
Yeah, it's fairly similar to the old General Assistance Program, exactly. What's really exciting about this opportunity is that the costs of the new population will be 100% paid by the federal government for the first 3 years. So for calendar years 2014, 2015, and 2016, the federal government will pay 100% of costs, right? So we know that Medicaid is usually, the state puts in some money and the federal government gives us some back. It's a match program. That is not the case for this new population. It's completely unprecedented in the case of health insurance or public programs in general. Additionally, so after those first 3 years, the federal payment will gradually reduce until it reaches 90% by 2020. The law is written to say that that federal payment can never go below 90%. Obviously, things can happen between now and 2020, but it'd be pretty hard to change. There are 600,000 people in Illinois who will qualify for this new Medicaid program, slightly more than that. A lot of these individuals, again, are childless men. A lot of them are 19, 20-year-olds who are aging out of all kids. It's a really exciting opportunity to provide a lot of coverage to a huge population of people, importantly without putting further strain on the budget here in Illinois. That said, this is the only thing that the Supreme Court changed. So in the Supreme Court decision, the majority of the law was upheld as it was. The Supreme Court, however, made this provision optional. As the law was written, it said every state must expand Medicaid. If a state does not expand Medicaid to this new population, they don't participate in Medicaid anymore. States have been participating in Medicaid for more than 20 years. Medicaid accounts for about 10% of most state budgets, and as a result, states panicked a little bit. So the Supreme Court said the federal government can encourage requirement, it can pay for, or encourage expansion, it can pay for expansion, but it cannot require expansion. So this means that many states had to take an extra step in some way. They had to opt in to this Medicaid expansion. Some states had it easy. All they had to do was have the governor say, we're going to do this and issue an executive order. Illinois did not have it that easy. So in Illinois, we actually have to pass legislation because we have a law in the books from 2010, I believe, that says no new Medicaid populations. So we've got Senate Bill 26 in place. I'm going to pass around this fact sheet for you all. Senate Bill 26 has already passed the Senate and is currently awaiting action in the House. And it just says Illinois will expand coverage to the new population so long as the federal funding never goes below 90%. Quick pause.
So I'm sorry, basically the big difference is now to qualify for Medicaid, you just have to be, it's just financial, not under this category.
Exactly, yep. The big difference now is it's only means tested. So right.
Raise it up, what did you say, 138%?
138%. So if you want to get technical, it's actually 133% with a 5% income disregard. So I don't usually tell people that, but I think we're going to start seeing a lot more information about the Medicaid expansion, and people get confused because they see the two numbers. So it's 133%, 5% income disregard, makes it effectively 138%.
What is that in money?
138% of the federal poverty level is like 15,700.
Cook County.
Mm-hmm. Yeah, it's just barely higher than the current eligibility for Cook County, or for county care. So Senate Bill 26, I passed around the fact sheet. This is what we're giving to legislators. You'll see it's 3 pages, but the first page is the only one that tells you about the law, right? Because it's really straightforward. It does not talk about capacity to serve these folks. It does not talk about the benefits package for this population. It doesn't talk about reaching out to this population, educating them, right? If I'm a 45-year-old male who's been uninsured for the last 20 years and has never had access to a social service program, I'm not going to wake up on January 1st and decide to apply for Medicaid, right? Somebody needs to tell me that I can. So the second 2 pages are the list of organizations who are supporting this. If you don't see an organization here that you think should be here, there's an email address at the bottom of the page. My boss, Katy Chan, email her. We'll talk to that organization first, and if you're interested in being added to this list, email Katy Chan. It's really important that we get as much support for this as we can, because it does not talk about all of those things I told you it doesn't talk about, right? We have until January 1st to decide how we're going to educate this population, how we're going to cover this population, and who in the world is going to be the doctor for this population. So it's really, really important we make this happen very quickly. That said, if this gives you a little bit of hope, you'll notice the first 2 organizations listed are the Illinois Hospital Association and the Illinois Chamber of Commerce. Very strange bedfellows for us. So we're cautiously optimistic that this can pass the House. That said, I will also leave a petition up at the front of the room, a good old paper petition. If you are interested in showing your support, you can just sign this, give me your email and your address with zip code. This should be your home address. I know sometimes people put their work one. And I will send an email to your legislator on your behalf when we know it's going to matter. I think we're really close, but right now it's still sitting in the Rules Committee in the House. So in the next couple of weeks, you'll see an email appear in your inbox that says, thanks for sending an email to your legislator. That was me. So the last part of this, right, is the new marketplace. This is where the Venn diagram will be the best visual, because you'll actually access new Medicaid and tax credits and subsidies on the marketplace. But I tried really hard to find a good one in PowerPoint and just couldn't. So marketplaces will really be the most transformative change for us as we look until 2014. So in 2014, this is the first slide on the second page. Well, I guess it's technically the third page. So beginning October 1st of this year, which is now only like 5 months away, marketplaces must be open for enrollment. All plans sold on the marketplace have a start date of January 1st of 2014. So we hear a lot about 2014, but this is actually coming in 5 months. The marketplace will be the place where most people are purchasing health insurance. In 2014, it will primarily be used by individuals, either accessing public or private health insurance, and small businesses, meaning businesses less than 25 employees, full-time or full-time equivalent employees. It will also be used by elected officials. That's by law. It's a little thing built in to make it work, though that's really hard to make elected officials work. well. So the marketplace in 2014, these folks will all come into the marketplace and they'll fill out a single streamlined application. It is one application that will collect the information needed for private health insurance, for public health insurance, and to access those tax credits and subsidies. The idea being that somebody can go on the marketplace at the beginning of the year, fill out their application for, say, private health insurance. Maybe I'm working, but my employer doesn't offer coverage. And then partway through the year, maybe I lose my job. All I have to do then is go back to the marketplace and say, hey, my income changed. And the marketplace will move me into Medicaid. I'm not going to have to fill out these applications over and over again. The population that this will most greatly impact are those folks who move between Medicaid programs. So you think about a pregnant woman, right? A pregnant woman goes to the doctor for her first prenatal visit. She's uninsured, so they have her fill out paperwork for Medicaid presumptive eligibility. That will cover her early prenatal care. So then she also fills out an application for moms and babies, which will cover her later prenatal care and her labor and delivery. Then as she gets closer to delivery, she's going to fill out an application for all kids to insure her child, and family care to insure herself. So in the period of a known pregnancy, right, which is even less than 9 months, a woman has filled out 4 different applications for health insurance. 3 of those applications were for herself.